Welcome to Combos from the Couch by LifeStance Health, where leading mental health professionals help guide you on your journey to a healthier, more fulfilling life. Hello, and welcome to another episode of Combos from the Couch. I'm Nicolette Lianza, and joining me today is LifeStance psychologist Dr. Kristin McGregor, and she'll be helping us to understand more about why integrated behavioral health is so crucial to good and effective care for patients. So welcome back, Kristin. Always great to have you on.
Thanks for having me. It's always great to be here and to chat with you about all my favorite topics.
Definitely. So as we get started, tell us a little bit about yourself and what led you to an interest in integrated behavioral health, or IBH.
Awesome. Yes. So I am a psychologist by training. I focused my career in what's called health psychology, or you might have heard of behavioral medicine. And basically, that just means understanding the intersection of emotional and physical health. So for so long, those things have been separated, and at LifeStance, we really want to focus on whole person care. And so that's where I spent my training and education, and then ultimately how I found myself doing this work. So I've worked in integrated settings across both primary care and specialty medicine. So I've worked in diabetes, I've worked in a women's health and infertility clinic. I worked in hospital settings where people were hospitalized for their chronic health conditions. So I've done sort of the broad spectrum of integrated behavioral health work, and it's really the only way that I prefer to practice. And so now at LifeStance, I'm lucky enough to be able to build integrated behavioral health programs across the country and help our PCP and other referring provider colleagues understand why this is such important work and why full-on integration is really the best way to address folks' behavioral health symptoms in a whole person way. So I feel really lucky to be able to do that in this role now.
You seem so wonderful and passionate about your job. And that definitely comes across. And I know I appreciate that because this is a very important thing. I think mental health and medical health has been separated for so long. So I'm really glad we're definitely kind of finally integrating it.
Uh,
Definitely.
Me
You
too.
know. So as we jump in even more, so what is integrated behavioral health, or IBH, and the collaborative care model? What are both of those?
Mhm. So, integrated behavioral health, or IBH, like you say, is a broad based term that essentially just means putting behavioral health where people go to receive their medical care. In many settings, that means like a therapist, a licensed therapist, or a psychologist. And so that person is typically spends time either in person or virtually dedicated, now that we're able to do so much telehealth and behavioral health, to a medical practice. And the idea is that person really works directly with the patient's provider. Notes are kept together, so we're documenting in the same EHR. Typically, that person will maybe join huddles or rounds with the PCP, so that the intention is to really engage in shared treatment planning with the person's referring provider. Now, with collaborative care, that's a really specific type of integrated behavioral health. And so it does incorporate a clinician. At LifeStance, we use a licensed clinician, but there's a little bit of flexibility in who can serve in that role,
Mhm.
who's engaging in behavioral health interventions for people that are experiencing kind of broad-based mental health symptoms. There are a couple of nuances to this model which make it really cool, and this is the IBH model that we use here at LifeStance. The first is another role on the team is a psychiatric consultant. And so in this role, we use LifeStance psychiatrists in this role who meet with our therapists weekly to go through patients that are enrolled in the program. And so that psychiatrist is able to provide the referring provider with medication recommendations for the referring provider to follow up on. Often they're also making recommendations around draw this lab to rule out this medical condition that might be
Okay.
contributing to the symptom. And so it's really been a game changer for our PCP colleagues who are doing so much psychiatric medication prescribing. So they're able to have like a safety net and a consultant to talk through, like, I've tried these two antidepressants. I don't know what to do next. Should I dose it different or whatnot? Like those are things that wouldn't necessarily need a psychiatric evaluation, but it just needs a little bit of support,
Yeah. Yeah.
which is pretty cool. And so then the last thing that's unique to collaborative care is that all of the patients enrolled in the program are tracked in a registry platform. And so through this platform, we're engaging in measurement-based care. So we're sending out like PHQ-9s or GAD-7s to measure their depression and anxiety scores, and then sort of watching what's happening over time and modifying the treatment plan as indicated. Like if the patient's not getting better, that might be an indication we need to change what we're doing. And so it allows people to get better really quick in this model,
Mm.
because everybody is sort of working together to optimize all parts of the person's health in conjunction, as opposed to, what happens in traditional settings, like you get a referral, you
Right.
got to wait for the appointment, then you get
Right.
another referral.
Right.
And so people tend to get better really quick in this model, which is pretty awesome, both for the providers and for the patient.
And so to piggyback on that, let's get more specific. What are the benefits for patients, providers, and health systems? I think you've already alluded to quite a few of those, but can you tell us more about that?
Yeah, absolutely. So, like the fully integrated model. So that this is really what collaborative care is that like everybody is on the same team,
Mhm.
everybody is working together at the same time in conjunction with the same goals. When people work together like that, patients get better faster. So, what the research shows and what we have demonstrated in our programs here at LifeStance is that from like the time of care engagement to the time of what we call remission from symptoms, which really is like subclinical, like not symptoms to meet criteria for any mental health diagnosis, that time is like 100 days. That's
Oh,
for 4 months, right? From
okay.
like, and these are people who are experiencing like moderate to moderately severe symptoms of depression and anxiety. Whereas in
Okay.
usual care, people can be in treatment for years
Yes.
sometimes,
Yes.
before they
Yes.
experience remission from their
Right.
symptoms.
Wow.
And so, it's not that every single person is the exact right fit for this type of care. Like the treatment is quite targeted. It's really focused on like current symptomatology, improving their functioning. And so some people do need, like you think about the person with like chronic trauma who really needs somebody to see weekly for an hour, sometimes for years at a time to really tackle
Hmm.
those symptoms. But
Yeah.
the other thing about collaborative care is that because we're able to contain a lot of the care within primary care, especially for people with like moderate, mild symptomatology, we can protect those often coveted outpatient slots for people that really need that
Wow.
level of care.
Wow.
Um, help the folks that don't necessarily need weekly hour-long psychotherapy to feel better more quickly, and to often prevent, because often sometimes when people sit on wait lists for a really long time, they
Yeah.
end up in a crisis before they
Yeah.
can get treated, kind of prevent that escalation of symptoms. So those are definitely the patient and the PCP benefits. But
Hmm.
for health systems too, like this is actually a really cost-effective way to deliver behavioral
Yeah.
health care, because our clinicians in collaborative care, they're often seeing a much higher panel of patients because they're doing like the briefer, more targeted work. So they carry patient panels of like 80 patients at a time sometimes, which feels
Mhm.
like a really high number. But when you're doing kind of the briefer interventions in a half an hour or a session every couple weeks, you can take care of more people at more like
Yeah.
in like a shorter time, essentially. So health systems really like that because there's such a push to contain cost of care for patients. And so being able to do this, like get people better in a cost-effective way, is really attractive to health systems.
Definitely. So what makes it different from other behavioral health treatment models and settings?
Yes. So I've alluded to this a little bit already, but really from like a clinician perspective, from the clinicians practicing in this model, it is faster paced. Like you think
Okay.
about a fast medical setting, right? Like that's the setting in which we're providing behavioral health care. And so it's quicker paced, more appointments, more patients with, like I said, more sort of targeted interventions. We're not doing in-depth, like I said, trauma work, like in-depth childhood work within this
Okay.
model. We are teaching people quick interventions like behavioral activation, which is basically just like getting out and doing activities that you
Right.
used to do
Do the
before
things.
you
Right.
became super depressed, right? So it's
Mhm.
really those kind of like practical targeted interventions that we're doing within the care model. And so that's different from like a traditional psychotherapist who might
Mhm.
be doing more in-depth work. And these folks are seeing lots of patients a day, like sometimes 8, 9, 10 patients a day versus the 5 or 6. And then there's often a lot of care coordination involved within the treatment model. So one thing about collaborative care is that there are specific billing codes that go along with collaborative care. And so care management is actually part of this model. So not only are we doing intervention, right, like you would think about traditional psychotherapy, we're also helping people like maybe get connected to community resources that they might
Very
need,
important.
where we're engaging in case consultation with the PCP and with the psychiatric consultant to make sure everybody's sort of working together on the same team. So it's diverse work too for the clinician. So those are some of the primary differences. The other thing that's a little bit different too is that our clinicians are never closed to care. So access is such an important kind of mantra
Yeah.
within integrated behavioral health.
Yeah.
Like you need to be able to serve the needs of the clinic, and you can't do that if you end up being closed to cases. So they're always accepting new people. They're always open. Like that's sort of, I'd put it on a t-shirt, like you're never full. You're never closed to care. And so again, that can be a really great fit for clinicians that
Mhm.
like this type of work. But you can see like for someone who's more trained in kind of traditional psychotherapy, this work wouldn't be that fulfilling, I think,
Right.
for them,
Yeah.
for those folks. Um,
Definitely.
so when we're hiring clinicians to be a part of the program, we're really focused on those that really like that like multidisciplinary work, working with
Mhm.
lots of different types of providers and really like diversity in their job and being able to sort of think quick
Yep.
and make quick decisions, which it's not for everybody,
Right.
but
Right. Right.
I love it, but it
Yeah.
doesn't mean every clinician does.
Right. No, I hear you. I'm on the same page as you. I like the variety for sure. So what populations does this model work for?
Yeah, that's a good question. So the model was developed decades ago, actually,
Yeah.
and it was really at the time kind of focused on people with depression, older folks with depression. But since that time, there have been oh, almost 100, I think, research studies utilizing
Wow.
this model across lots of different patient populations.
Mhm.
And basically for everyone that's been studied, they've shown that it's been beneficial. So people with depression, anxiety, of course, and then folks with PTSD, even dementia, women's health population. So like you think about menopause and
Right.
postpartum
Postpartum.
depression,
Mhm.
things like that. So it really does work for a wide range of presenting problems. There are certainly folks, like we talked about a little bit earlier, who just need more than what this model is able to offer. They might need a psychiatrist because their medications are complex or their health condition is complex enough that they need another physician or advanced practice provider on their team. There are folks who have 2, 3, 4 mental health conditions that they need
Yeah.
to address at the same time, right? Like there are people who have needs that are outside of this model. But what's really cool about this model too is that really the intention is to be like the front door to the mental health system. So often I think many of us have had this experience where we go to our primary care provider, they want to refer us to a specialist, you get a list of people in the community and you have to call. With
Right.
this model, you go to your PCP, you check out at the desk, you make an appointment with your clinician, Kristin, and then we meet and we might find out like, geez, like you really could use like a clinician who can do trauma focused work with
Right.
you.
Right.
When I refer that person, because we've already met, we've kind of talked about what the patient wants. I'm a clinician myself, so I know what might be a good fit for the symptoms that they're telling me. When I refer that person, they're like almost 100% likely to show up to
Ah,
that appointment. Whereas if the
okay.
PCP refers the patient, gives a list,
Right.
half of the people usually show up. And so that's the other thing that's cool about this model too, is that we're intended to like bridge people to the care that they need to get to at the time they need to get to it. and they're
Mm.
way more likely to go if they've come through an integrated behavioral health clinician. And we've seen that in all of our programs, that when we refer, because we can make a good match, we can follow up and make sure that they went. And if they didn't, we can talk about why.
Mm.
And so really just making that connection to the rest of like a very complex system that's difficult for people to navigate,
Yeah.
um, is part of the benefit too.
Yeah. Whew, so many benefits for sure. Please share with us some patient success stories. I'm sure there's so many that you have.
Yeah. Really, I mean, I have so many favorite parts of this work, but one of my favorite parts of this work is when we get to see people who never would have gone to a mental health provider ever. And we hear that all the time, that like, if you weren't right down the hall, or if my PCP didn't name you, I would never have come, or I didn't think my symptoms were bad enough to go. Like,
Mm.
right, like people usually wait until they're like in a crisis to make a call. Whereas
Mhm.
here, if they're identified early, we had this one gentleman that one of our clinicians who's working out in California saw. This man in his 50s. He had a long-standing history in the military, was experiencing symptoms of PTSD, but he was like, I'm not bad enough. Like my peers are worse off than I am. But he had gone to his primary care provider. He had elevated blood pressure, and he also had elevated scores on his PHQ-9 and GAD-7, depression and anxiety measures.
Mhm.
So he did agree to see our clinician, and she didn't, like he really wasn't the type that would have wanted like full on trauma treat. He wasn't ready, but
Mhm.
she was able to give him some education about his PTSD symptoms, give him some tools to help him manage when he gets super elevated. He had tried an anxiety medication in the past, but it had made his blood pressure go up. And so then
Mm.
we were able to use our psychiatric consultant to make some recommendations to the PCP, to try a different medication. And in 2 months, his scores went from in the moderate range to in the minimal range, which is essentially like remission
Oh,
from his
that's
symptoms.
amazing.
It was amazing, and like so fast. And it even surprises our clinicians sometimes, like how fast people get better when you can really optimize both the behavioral intervention and then the
Right.
medication at the same time. And so he may need, more sort of process type trauma treatment for his time in the military, but for now, like he feels empowered to manage his symptoms himself. He understands what's happening in his body, and so he doesn't feel like he's as out of control. And he told our clinician, like, I wouldn't have gone if you weren't sort of
Wow.
right down the
Wow.
hall and connected to my PCP.
That's helped change his life, quite literally.
Absolutely. And he's more likely now to go. Like if he needs treatment again, he had a nice experience with the mental health system.
Mm.
That's really part of the goal too, right? Is to just give them a good experience and then make them more likely to come back
Right.
before entering a
Right.
crisis.
Right. Definitely feel
So
better.
yeah,
Yeah.
exactly. And giving them tools. So she continues to kind of meet with him to maintain his gains and to also talk through like, in the future, if this happens, what are you going to do? Right. And like,
Mhm.
how do you know when to call me to get back into care versus just like using the tools we've talked about together. So
Right.
that was a
Right.
really
Oh my gosh.
compelling case, I think.
Definitely. Oh my gosh. Thank you for sharing that.
Absolutely. I'll just share one more
Yes,
too,
please, please.
because this one is really lovely as well. So the same clinician saw a woman in her 70s. Again, never had seen behavioral health treatment before. She's 70 years old, and her husband has dementia. And so she was feeling low and isolated and hopeless and those types of things. And even after one session, she just sort of like talking about what was going on, she felt like a weight off of her
I'm
shoulders.
sure. Right.
Because
So
right,
many
such like
years
an
of probably just not
isolating
talking about it either, right? Right.
100%.
Yeah.
Absolutely. And so really all they did was just like problem solve how she can continue to do things that make her happy outside of being a caretaker, right? And like empower her to do those things and give her permission to do so. And yeah, just a handful of sessions was really all she
Yeah.
needed to feel empowered to kind of get that part of her life and her identity back and those
Mhm.
things. And again, like she wouldn't have called our office.
Right,
She
right,
went because it was right there. And so that access to care is just it's such a benefit of this type of
right.
work.
It's a benefit and it's so crucial. And I think the importance of our conversation today is to make sure we're still pushing this along to expand us even further and to make this the model of care, right? So making sure that we can kind of move to this as our standard of care, right? Because it works. It works.
Absolutely. Absolutely. It does work. And I agree. And I think it's a benefit of our system that we really do have that kind of broad, because you need that broad spectrum of care. We need the specialists, we need that higher level of more specialized care, and I feel like we also need the mechanism to be able to take care of that whole person and all kind of
Right.
work together in service of the patient. And so yeah, it's pretty awesome to
Again, I can see that passion coming out and your genuine happiness for what you do. You see the benefits of the care that you're
I
providing
do.
and the model and all the things. So, Kristen, it's always amazing talking with you. Thank you again for coming on to share this model with us
Yeah,
today.
thank you for having me as usual.
I'd also like to thank the team behind the podcast, Jason Clayton and Juliana Whitten. Thank you for listening to Congress from the Couch. Take care, everyone.